No. All right. We will go ahead and call to order. Just a reminder, this meeting is being recorded, so everything said in the room or online in the meeting will be a part of the permanent recording that is shared to the Bureau's website. We will go ahead and do a roll call. Shelley, go ahead, please.
Amber Rice. Daniel Spate.
I'm here.
Franco Castromarin. Frank Walter.
It's generated 750.
Gail Bradley.
Present.
Eve Godstanker.
People, and the add value.
Jason Johnson. Josh Gaither. Julie Augenstein. And Kevin Foster.
I'm here.
No, 6. I need 7.
Dr. Godthinker, who just
Oh.
joined as well, but I think we have kind of myself, Dr. Godthinker, Dr. Bate, Dr. Castmarin, Dr. Gaither, Dr. Foster, Dr. Johnson, and Dr. Rice.
Oh, Franco came on.
Yes. I heard, Dr. Castmarin, I think we heard you come off mute. If you can just confirm from roll call purposes, please.
Yes, I'm here.
Excellent. Thank you so much. All right, we have quorum. Thank you, everyone. Just a reminder, the attendance report is in your packet. If you do miss 2 or more meetings simultaneously, we will reach out to you to confirm if you would like to still be a member of the committee. There are currently 2 vacancies that are still on the that are still present. One is for a physician who specializes in severe acute head injury treatment or spinal cord care, and it was demonstrated an interest in or expertise in emergency medical services. And the second is emergency physician serving an EMS council, which then moves to the Western region. So that position is still open as well. Anyone who is interested in serving on the committee for these openings, or if your term is expired or nearing expiration, please make sure you submit a reapplication on the Governor's Board website that is linked on the agenda as well. I briefly wanted to touch on the naloxone leave behind program, just to really share with this committee the significant success that we've had. I don't have the numbers on us here, this slide here, but we have over 3,500 EMCPs that are currently trained in naloxone leave behind in the state of Arizona. So that is over 15% of all EMS providers in the state are trained in naloxone leave behind. In addition, we have shipped out around 4,800 kits and have EMS providers have scanned nearly 600 kits, which means that they've actually scanned the QR code to identify that that's been given out. We recognize that many more kits have been distributed that have not necessarily been scanned, but just wanted to say a big thank you to the medical directors who approved their agency's participation. 47 agencies across the state of Arizona are currently participating. This is a much higher number than I think we have, any of us thought we would get. And a big thank you to the agencies, the EMS providers, and medical directors for supporting this program. We really feel this is a huge benefit to the citizens of Arizona. So just wanted to highlight that as well. We will move on to the Bureau report next. We will do kind of a little bit of a tag team on this one, and I will turn it over to Nicole.
Great. Hi, everyone. I'm Nicole DePuy-Witt. I'm the Assistant Director of Public Health Preparedness at ADHS, which includes the Bureau of EMS and Trauma Systems. I don't normally speak or join these meetings, but given the transition, I'll be attending and tag teaming with Dr. Bradley and Deputy Bureau Chief Noreen Adeline. We just wanted to give an update on our recruitment. So we are continuing to recruit for the Bureau Chief for the Bureau of EMS and Trauma Systems. That recruitment actually went up in November, and it will remain up until we fill the role. So if you know anyone that is interested or qualified, definitely encourage them to apply. And we'll continue to give updates on the process, but we are committed to making sure that we find the right person for both the Bureau and ADHS, their stakeholders, and certainly Arizona. And so we'll take as long as we need to fill the right candidate for that role. We also have a number of other positions. We are aware that we have a number of vacancies across the Bureau, and we are actively recruiting for each one of the positions that is listed on the slide. And so if you have any questions, we're happy to answer those related to the process. But again, appreciate your support in referring individuals that might be qualified and interested in working with the Bureau to any of those positions. I think that is it. I'll turn it over to the next, just because I am not an expert in everything. We are taking turns and giving updates.
All right. So next I want to just cover our upcoming awards. So the EMCT of the Year Awards and the Trauma Award. So this will be our third year doing the EMCT of the Year Award. The nomination process did go out to the 4 regional councils, so you should have gotten communication about that. When you do nominate someone, things to consider are listed on the slide. The next slide. This slide deck will go out to everyone. If you want to nominate someone directly, you can click on that link to nominate someone from your region. For the Trauma Awards, this will be our second year doing the Trauma Awards. This will go out, it has gone out as well widely. This is not necessarily only going to be to the regional councils, but really more from the trauma community. There are several categories you see here, including Trauma Program Manager of the Year. On slide back, please. Sorry. That's okay. Trauma Medical Director. There's Trauma Registrar of the Year, Injury Prevention Achievement, Research and Academic Achievement Award, and then also Pediatric Champion Award. Last year, we did not have any nominations for the Pediatric Champion. So if you know anyone that is actively engaged in pediatric trauma care, please take the time to nominate them. But the nomination is here. Just a reminder, the Bureau staff does not participate in any of the decisions regarding who gets these awards, as we are the regulatory body for both groups of nominees. The regional councils will elect their EMCT of the Year award, and the Trauma Awards, there is a subcommittee that has been put together with members from several of our different trauma committees, trauma program managers, trauma registry users group, and we're hoping for a couple of staff members as well. So that will be decided by that group. Nominations close on March 7th, and April 4th will be the when winners are chosen. That will give people some time to hopefully arrange their schedule to come and participate in the meeting in May. May 8th, we will have the award ceremony during State Trauma Advisory Board meeting at 9 a.m. and then during EMS Council at 10:30. I think still have a very nice larger conference room to accommodate. We have many members that come. They bring their family members as part of this program. So we want to make sure we have space to accommodate that moving forward. EMS portal changes. Lithia, if you just want to cover it briefly for this group.
Yeah, so some of the changes that you're going to see is we're updating our website to have the new logo. So we're updating all the applications, the main page with the new branding that we have. And then all the emails that are going to be coming from the EMS portal, instead of being not replied at acdhs.gov, will be the one highlighted, acdhs at arizona.emstrandlicense.com. So you will be seeing that. And then if your agency has the rosters for the EMCTs, make sure they keep updating them, as we're syncing our system with the lead, and we want to have the most up-to-date information.
Thank you. And just for everyone's awareness, the new logo, if you look at the top of the agenda, that is the new logo and color scheme for ADHS. So if you receive communication, it is not spam, that is the new logo. So we're just trying to get that messaging out to everyone and really make sure your EMCTs, all your medics and EMTs know everyone is comfortable opening .gov email addresses, that this is going to be a .com. So just making sure people are aware that they do actually open this email address, and this will be what they need to use to get recertified. Next slide. We will just quickly cover this one, David.
Yeah, the statute and rule books has been updated as of January 21. It's on the Bureau's website under the regulatory references section. It includes the statutory, the legislature, and the GERC approval changes that were ran through. So feel free to read through that. All the tables 1, 2, 3, etc. They've all been included. Links to for updates for that as well. And then the governor's office of highway safety, they do have the grant program. The Bureau's been a collaborative partner with QHS since about 2006. It's a good way to apply the pre-obstacle care and post-crash care and highway safety to reduce crash fatalities. We've had 2 grants so far. We're working on our second one right now that primarily covers the cost of our EMS and trauma registries. And also we put together a work group each time to help us see how we can demonstrate ways in which the data is being utilized to cross it over to like ADOT and other agencies that deal with crashes, show how we're improving it. And then the grant for the 26th federal fiscal year is due March 7th. If anyone is interested in looking at the grant categories that are available, please send me an email and I'll send you the link to review that at the Governor's Office of Higher Safety website. That's all. Thank you.
Thank you very much. Just a reminder, I think everyone in this committee is well aware, but the scope of practice that this group worked really hard on, and it's finally up and live. That is linked to the Bureau's website at the bullet point on the main page. A big thank you to this committee as well as the PMD for all of your work that went into producing the updated scope of practice to add the critical care endorsement for paramedics along with the EMR column. This also includes all the work in updating the drug table. I definitely wanted to mention with the drug table, the big change, and all of you are aware, but just to make sure if any of the physicians on the line, that the hospital-based paramedics, which is table 3B, there are pretty substantial changes to that one. We have increased the number of topical and oral medications that a hospital-based paramedic can use, but more of the critical care related medications have been moved from a general paramedic to the paramedic with a critical care endorsement. So just to make sure that facilities are aware of this change. And then in addition, table 1 has the 2 new columns for the EMR and critical care endorsement as well. So a big thank you to everyone in this room and online for all of your work in getting these approved. I think this is a huge benefit for the state. And lots of lead time we covered, but I'll turn it over to Adam for the MARC program.
Right, Adam, Aubriana did that conference promoting the EMT program, but from her death, we produced the recognition program that is the counterpart for the hospital pediatric excellence recognition program. This recognition program, which we're calling the MARC program, Making Arizona Ready for Kids, is the pre-hospital recognition for pediatric excellence available to EMS agencies and fire agencies. The way the program is built, there's an application window. That application closes February 14th. Please contact myself or Aubriana Smith if you'd like more information regarding that program. Next slide, show. And then a quick update on share. We're working with a hospital to maintain their proceeding referral recognition. We're also working to finalize the share database in preparation for developing the share annual report. That in collaboration with a lot of team members and data and quality assurance. We're working very hard on that. Additionally, past share reports and other resources can be found on our Bureau's website. You can reach out to me or my counterpart in the DQA area. That is Josie Johnson, if you have any questions regarding share. Thanks.
Thank you. And just a reminder, continuing with our share program for agencies that are premier EMS agencies. This was updated and approved by EMS Council last May to really make the data elements for cardiac arrest now a requirement to maintain your PEEP status. The good news is that if you're a NEMSA 3.5 compliant EPCR vendor, which almost everyone in the state is, these data elements are already built into your platform. The goal of this is to make sure that we automate our data. When we look at the initial share program, this was based on really a ton of man hours reading narratives to get the information for the share database. With the advent of all the technology changes over the last 18 years, we really have the opportunity now to automate that data. And so our goal is to improve the data quality and have it be more automated on the pre-hospital side. So EMS Council did support that change. In May, we have been circulating this information to EMS agencies, but wanted to make sure the commission is aware of that as well. With this, some agencies have been asking, how are we doing? The short answer is we don't know yet. So I think to hopefully set people's minds at ease, the first quarter of data started January 1st. We're not yet at the end of January, so we don't even have January's data yet to compare. But really, as we start getting 1 or 2 months worth of data, we will be communicating with all PEEP agencies of how their data looks in regards to these elements. So more information to come. We're not going to take someone's PEEP status. We really want to help ultimately increase the data quality and make it more automated. So wanted to put that on everyone's agenda. Just a few quick slides on our GIS and data information. The slide deck, which will go out after the meeting, does have a link to multiple maps that you can go into and adjust, and also link to our dashboards. Boswell and her team have an incredible amount of information that they have created and put on our website under the DQA section. This information has been used by some agencies to actually get pretty large grant funding to support different programs. So really encourage people if you're looking for data relevant to your community, to your county, et cetera, please feel free to go to our website and look at some of those dashboards. You can use those as you see fit.
Yeah.
We can cover this very quickly. I think for most of the room, this is just an update. I think most are aware that there's an RFP that was open for the trauma registry. That did get finalized and was awarded to ESO. Carissa has been doing extensive communication with all the trauma centers. And there's a trauma program managers workshop that I think Kim, you said there's almost 60 people RSVP'd for in-person tomorrow here in the Phoenix area. So anyone in the trauma community knows how to reach Carissa. She is the point of contact, but that is finalized and done.
Yeah, and just a huge thank you again to all stakeholders for their patience with us and our lengthy RFP process, but we're glad it is closed and I think it worked out hopefully the way everybody would like it to. The last item, I think I'm me. So just wanted to give an update to everyone that well, David already spoke about our statutes and rules are updated on the website. We meaning the team also went through our guidance documents and substantive policies, again, to just remove any language that wasn't aligned with the new statutes and rules and or completely remove any items that were not aligned with the new statutes and rules. So that has been completed. And so if you were to go to that section of our website, they have all been updated as well. And I think we can answer questions if anyone has any questions on either of those items.
Next, we'll go to our standing committee report. I know Dr. Ogden can talk about it. I think Shelley's got the report from TEPI.
I'll cover it, y'all. The November TEPI meeting, they approved their meeting minutes. Adam shared info on the TEPI shared user group meeting that was held November 6th. Julia shared a data opportunity with the outcome of a ADOT Governor's Office of Highway Safety Grant Work Group. They also discussed the pros and cons of displaying the number of agencies that report to AZ peers. Not a voting item, but consensus was to have an annual number posted on the snapshot area of the data dashboard. The ADHS heat-related surveillance dashboard was displayed. The group talked about PEDS drowning data, and then Adam shared the Heart Safe program. They were streamlining the application to make it easier for entities to apply. And the reports.
Thank you. All right, next education. I think it's you speak loudly. It should be good. Thank you.
All right. So Dan Majewski shared information on the psychomotor exams and then how program directors and medical directors can generate and attest to these results, which can then be sent to the state. We also approved the safe sleep training, which is now posted, as well as TXA training, which is also posted. Julie and Rachel shared slides about the outcome of the paramedic educational grant in the region. Then we talked a little bit about the Gov delivery bulletin regarding the changes on the scope and drug tables. We voted to approve forming a joint work group with PACES to make training for children and youth with special healthcare need. The first meeting actually was in January 16th, with the second meeting to be determined. Then for the upcoming meeting in March, request was made to add in the Arizona ALS training pass-fail rates for the first attempt on the paramedic exam, and then also to add the pass-fail rates for the psychomotor assessment, and then with a plan to form a work group on the testing process.
Okay, thank you. Dr. Gaither.
PMZ, we approved the meeting minute. We talked a little bit about the drug table going up, we've already talked about here. And then we also reviewed what is attachment 6B, that we're going to review later on in this meeting. Suggestions from PMD included that one, this is great, fabulous information. Thank you so much for putting it together. It really will help education and reviewing scope of practice in the future. And two, we discussed a little bit about combining the multiple epinephrine on this table. So it gives us a little bit more representative of what's going on.
Thank you. Adam, are you doing the PACES update as well? Thank you.
I will. Hi, everybody, this is Adam again. PACES met on November 21st. The minutes were approved as presented. Bachel shared some quail kids and ATD data from that program. Morgan Anderson shared some information from the Arizona Child Fatality Review. Dr. Kate presented U of A's new quality improvement toolkit, which is live on the SHARE website. There were 2 role description guides approved for both hospital-based techs, pediatric emergency care coordinators, and EMS-based techs. There was an approved joint work group with education to make some training for children and youth with special health care needs. So thank you for those of you that participated in that. We already had the first meeting, and the second one is to be determined. The safe fleet training was updated as well at education. And Administrator Chris McCarthy, who was the representative of RAPM, Western Regional Alliance for Pediatric Emergency Management, highlighted the projects from the Pediatric Pandemic Network. And this was focused on disaster response preparedness for pediatrics in healthcare settings. Thank you.
Thank you. And I just wanted to highlight the work that is done by the Education Committee chaired by Dr. Rice. Really a huge thank you to that committee for the work putting together curriculum. If you're looking for training, especially as we are entering and in the National Registry renewal cycle, we have multiple really well done training PowerPoints that are available to download that you can utilize to train your agencies and your personnel. Those are updated every 3 years at a minimum. We feel like they are very much up to date and a high quality educational curriculum. So just want to highlight that those are available. Next, we will move to our discussion and action items. First, if I can get a motion to discuss, amend, and approve the meeting minutes from September 19th. Thank you. Second. Okay, we've got a first and a second in the room. Yes, thank you. Any recommended amendments? Hearing none. Any opposed? Any abstention? All those in favor say aye. Next, more kind of a discussion item, but if we can get a motion to discuss the medication report from AD Peers. Thank you. All right, we have first and second in the room. So big thank you to Anne for pulling this report together. These are in your packet. I know we did discuss this at PMD. I think this is really useful information. This is based on 2023 data, so Anne does have that action highlighted on there. But I think it is quite interesting when we look at medication. Some of the more higher utilized medications, oxygen being number 1, followed by saline, and then aspirin, and Zofran is the next 2 most common ones. And then we have others that are much less common, but we do still see utilized here. One of the things that we recognize when Anne sent these reports to me is sometimes we see medications that are not approved at all in the state of Arizona that end up on this report. And sometimes that can be simply a matter of someone clicked something in an EPCR system. If they click the wrong button, that comes across to us. We have also seen that we had a couple agencies that were doing a lot of arterial lines. So no one is doing arterial lines in the 911 setting, but we realized that their IOs were actually coming across as arterial lines in the EPCR system. So some of the data mining that Anne and Vox will do is to really try to interpret some of the data that they get. They will come to myself and Adam and say, does this make sense? And usually we can say, yes, it does, or no, something's really off with that data. And I know you're on the line. I don't want to steal your thunder in that, but I wanted to see if you had anything else to add in that as we run through the 911 list first.
Thanks, Gail. The only thing I wanted to add, and it could come at any point when you're talking about this, is at our last MSORG meeting, I mentioned this too for anybody that happened to be on that, but partly because of this issue that Gail just mentioned, and the same thing happens occasionally with procedures. There's going to be a report that I'm working on that'll be kind of a report that has several pages that'll go out automatically to whoever's on my list each month for each agency. And it will list every medication that they say they gave. So either prior to arrival, no, or prior to arrival, blank. So it excludes right now the prior to arrival yeses. If someone wants me to add those back in, I can, or as a separate table. But hopefully the idea being that whoever gets this at the agency will take us, just skim that list in addition to the other tables we have on that report. Because if anything looks strange, this is what we have for that agency, and we can address it hopefully earlier and determine what's going on. Maybe it was a test record that shouldn't have come over or whatever. But I just wanted to add that we're trying to be proactive in addressing some of the weird things that we see.
So thank you, Ann. So if you don't see those reports from your agency, it's probably worthwhile asking your agency, hey, do you get a report from Ann about things that we're doing? That way you can review that and see. Most of the time, what we recognize is an agency has either changed the code accidentally on something, and that's why we get the incorrect information, or they're just using a drop-down field and they click on the wrong item in a drop-down field, which is pretty easy to to occur as well. But I do think we, newer on our drug tables are acetaminophen and ibuprofen. So this is 2023, but we do have our students see some of that on there. TXA was also relatively new. I'm trying to remember when we approved that. I feel like it was sometime in 2023. So at least for that year, there was 145 uses. My guess when we get the 2024 data is we will see quite a bit more as more agencies are starting to utilize TXA. So I think it's useful. We've got some pretty low use items such as hydroxycobalamin or cyanokit. Fortunately, we don't want to use that a lot, but you see that as a pretty low utilization. And then vasopressin and oxytocin are the other kind of very small item ones that we see. Any questions or comments in the report from anyone else? One of the discussions we did have on the epinephrine is how do we capture kind of push dose epi? You can see the number of uses of dopamine. It's very small. It's 62. And I think many agencies across the state have converted from dopamine to push dose epi. Unfortunately, it can be somewhat difficult sometimes to capture, is the drug being administered as they push dose epi in a pressure form versus kind of an anaphylaxis or cardiac arrest dose. And then if we go to the interfacility drug table, you can see they're pretty variable with the medications. We have some that are used quite frequently and then others that are rather minimal use. But again, this is for 2023.
I have a question that I know I don't have an answer for, but I'm gonna, as we look at the pre-hospital medication, not in our facility, it's striking to me that there's a mismatch between the number of patients who are given accommodate and the number of patients who are either given rock or suck. And there's no other sedative on here besides Versed. I can't imagine people are doing RSI with Versed and.
I think people are using ketamine.
Oh, okay. That's good reason.
Yeah, so I think there are several agencies where they are using ketamine or etomidate as their induction agent.
Got it.
Which I think then is why there's that difference in number for the sucks and rock.
Maybe another really cool thing, I know you can't, but to talk about is how much ketamine is given for pain medication versus sedation. Very different use of the drug, like two different drugs.
Yeah.
I don't know if that's possible, but it's really cool.
I do it like doses, yeah. The amount.
It's like a dose like 3 or 4 milligrams, dose greater than 100 milligrams.
Right. I'd be curious.
And is that something that is possible to do in the report? I'm not sure.
Yeah, it's nothing, we do collect the dosage. If it's been documented, we haven't looked much at that, except for, of course, with epi, if they are indicating in the medication field, the concentration, that's why we can divide it out. Sometimes they don't. That's why you have 3,000 just generic epinephrines. But certainly, I can look with Fotzel and Gale, and we can kind of take a look and see what we can do for specifically. Are you just specifically interested in ketamine? Because and we can pull and just see what people are giving us, and if it's important, we can also try to highlight to agencies the importance of making sure they fill in the dosage.
I think that one, especially because typically I think most pain control, we're seeing 20 to 25 versus everything else is usually a much higher dose. We should be able to separate those out as long as we have an actual dosing in milligrams. But with it being a controlled, we should hopefully have better dosing in for that than maybe some of our other medications, because they would have to demonstrate waste as well. Any other questions or thoughts that people want from the report?
I'm just going with questions or thoughts. Same thing with Narcan. It would be interesting to know how many of these are given intranasal versus IV and IO. Two very different uses, honestly, different clinical applications. That would be pretty simple, I would imagine, to.
Sorry, what medication was that? Just so I can write down.
For Narcan, so kind
Okay.
of comparing the intranasal versus all other routes. You know, one of the interesting things too, in talking to toxicology, they really said, you know, the intranasal was designed for kind of layperson, EMT, law enforcement, But when you look at absorption rates, we're starting to see some agencies where paramedics are utilizing the intranasal naloxone. The problem with that is it's much lower absorption. And so really from a toxicology standpoint, I know I've been doing a lot of teaching to say, if you have a medical scene, you want to be utilizing IVI or IM as your first line, as opposed to going straight to intranasal just because of the absorption rates with that. So that would be interesting to see. We might not be able to separate out level of certification providing it, but we can certainly hopefully see the route of administration.
And then your, sorry, like I said, full of random thing, your sodium chloride 0.9% and sodium chloride, that goes the same thing. I don't think we have half normal sodium anymore. That's it.
Yeah.
So.
That's
I would imagine you
combine those two.
Yeah.
So the question is, I think certainly combining the two salines are appropriate. When we look at the epi, we kind of discussed, do we separate? We obviously have a large number with no dose or no concentration because that's how we are receiving that in AD peers. But we do have some delineation with the other doses, which kind of get into your anaphylaxis, cardiac arrest versus push dose epi. So that's probably our best way of seeing how that looks. But I wanted to do the group things by keeping those separate. I think that's probably our only way to really have a gauge in how those are being utilized. And then a plug just for your agencies, if they're just putting an epi without a concentration, we would love to see a concentration, just so that we do have a better idea of what's actually being administered. Any other questions or comments or feedback for this report? Yes.
Oh, I was just curious, why is that ipratropium bromide higher than the albuterol?
I have the same question. Very bizarre.
That is a good question.
I don't think I've been a bad one.
That was weird.
I'm wondering if crews are giving multiple doses and just looking at one, but then it still shouldn't be lower than that.
Yeah.
That is a good one to maybe,
More albuterol than you do.
yes.
Yeah.
And sorry, what was the other one? I can't hear the albuterol.
Why is albuterol lower than ipratropium? We should see a higher number of albuterol versus ipratropium.
And I will say this is just to address something you were mentioning a second ago. This is limited to, so if they gave 3 doses, this is not the number of doses. This is like each patient, if they receive 3 doses of albuterol or 1 dose of albuterol, it's going to count as 1 in this report. So basically we didn't count doses, we counted patients administered to by that agent.
Yeah, so I think, and what the point of the committee is saying, which is a good point, is yes, recognizing that they might have multiple doses labeled as 1, we should still see at least equal, but typically more albuterol given than ipratropium, because the ipratropium should never be given by itself.
I just wonder if they're getting two and
No,
marketing it as ipratropium.
Right.
Like if it's just, like if they gave a duoneb, if they're just as attached duoneb, or maybe they're just selecting ipratropium on it as a duoneb. That would make sense, right? So a bunch of the duonebs are given and that was straight ipratropium.
Yeah.
So we don't have that on here, this list, right?
Mhm.
I don't know.
It's weird.
Yeah, it is unusual because certainly we know what, when you look at kind of medications that actually improve outcomes, and albuterol is one of those for bronchospasm related.
Yeah, because duoneb's not even on it.
Mhm.
So somehow they're documenting it, not as a duoneb, they're documenting it either separately or they're just documenting it for program.
Right. And on your ISTs, they actually look like they've got it right because albuterol 150 and ipratropium 100, so they're giving it 2 to 1, not 2 to 1, but almost. More believable.
Well, big thank you to Anne. This, while this looks very clean and simple, this is not a clean and simple report to produce. So she is taking in a lot of data, varying reliability at times, and producing a very clean looking report. So really big thank you, Anne, for putting this together. All right. Well, I think that is the end of our discussion and action items for today. I wanted to see if there's any items for our consideration to be added to the next meeting. So our next meeting is in May. Yeah.
A very astute company provider in our region did note
that, oxygen is not on the drug list for EMRs to use. Yet it is checked off as an approved scope. So the agenda item would be to add oxygen to the approved drug list for EMRs.
Thank you.
Sorry about that.
No.
Total oversight on all of it.
Thank you. Any other agenda items or topics that people want to discuss or look at? You do not have to tell us today. We have plenty of time before the next meeting, but if you think of items, reminder, if it is potentially scope of practice or drug table related, we do like to have that go through PMD first. So if you have anything that's scope of practice or drug table related, please send that to Shelley so that we can look at adding that to the PMD agenda, which is in March. And then our next MDC meeting, if it were to pass PMD, it would then be added to the MDC meeting in May. Next call to the public. All right, hearing none. Upcoming events are listed on the agenda. I will not read through those. A reminder that our next meeting is May 8th. We are off the third Thursday cycle. We have been trying to avoid some of our big kind of conflicting national conferences and statewide conferences, although there is a big one going on today, a couple big meetings that were overlapping this as well. But that meeting is going to be May 8th, which is the second Thursday in May. It will be, I believe, in another conference room that is larger than this one, and the full meeting schedule is hyperlinked to your agenda as well. And that is all we have for today. If I can get a motion to adjourn. All right, thank you.
Thank you.